So I'm delighted to welcome Graham Thornicroft to give the seminar today. Graham is Professor of Community Psychiatry at King's College London and consultant psychiatrist. Does lots and lots of other things. I'll just mention a couple of things quickly. His areas of work, he's going to talk about global mental health. He's very big on implementation science, knowledge exchange type stuff. He's very big on user involvement, on needs assessment, on evaluations, a whole range of things. He let slip just now that this is the first time for ages he's not writing a book, which I'm sure applies to most of us actually. But he is prolific in writing, and he writes in a very clear way and communicates in a very clear way. So I'll leave Graham to say more as he demonstrates how clearly he's going to present, of course. And I used to work with Graham. I worked with Graham on lots of things, and it's been a great enjoyment. So I'm looking forward to your presentation.
That's very kind. Thank you, Martin. Well, hello, everybody.
Hi.
So my brief is to speak for about 45 minutes, followed by about 15 minutes Q&A. If you feel like making a comment or question during my talk, that's great. I would encourage it. But I'm slightly apprehensive because you're obviously coming here on an empty stomach. You might be irritable as a hostile audience. So I have to take that risk. But if you'd like to make a comment or question while I'm going on, just simply raise your hand and I will sort of pause as soon as I can. So I'd like you to interrupt me. So my topic I've chosen here is strengthening mental health systems in low and middle income countries. Now, first of all, like everybody, I'm biased, so I want you to know about my sponsors in case you think that I am being unduly biased by who gives me money or things that I do. So on the left you'll see where I'm getting grants at the moment. On the right you'll see some of my current roles and responsibilities. So if you think that is skewing what I say, you're quite open to challenge me. So I want to start the scene with a short film.
"50 million people suffer from epilepsy. Depression haunts and hurts 150 million people. Almost 3,000 people commit suicide every day. In low and middle income countries, 75% of people do not get the mental health services they need. To reduce this huge gap, WHO developed the Mental Health Gap Action Programme, or MHGAP, in 2008. An epilepsy project in rural China integrated a simple model of epilepsy control into local health systems and achieved excellent results.
We trained mainly the doctors working in the county and township level. So we have to educate them first. And also we have the public education for the people, let them to know what is epilepsy.
话说白了就是没有经济来源收入，要供养的娃子上大学的，就是两个人奋斗，也就话说回来，这就说打3天睡1天，这复发的情况。近几年吃这个药，吃上相当好，在这个10个月这个基础上，家庭一人好一点，也能出个所生意了。那就说是我吃药之前呢，我都这样都不敢走。
The trial project that started in 6 provinces has now been extended to 15 provinces, and tens of thousands of epilepsy sufferers have been treated. Georgia and Cameroon are now also training primary care physicians on how to diagnose and treat patients with epilepsy. MHGAP, scaling up services for mental, neurological and substance use disorders. Services like the Cape Mental Health Project in Cape Town, South Africa, which offers care for children with intellectual disabilities.
We provide training in basic, call it basic physiotherapy, seating, positioning, feeding the children. That can be put in place. Those are skills that can be acquired.
This is my daughter Tara. She's intellectually disabled. When I started working with the cerebral palsy children, you just have a bond each child responds differently. But if you know how to bond with a child, it's just beautiful. It just all comes together and you know exactly what to do exactly at the right time.
MHGAP, tackling priority conditions like alcoholism, child mental health disorders, dementia, depression, drug abuse, epilepsy, psychosis, suicide.
In India particularly, following the failure in exams, almost 2,300 students commit suicide. So we have taken this as an issue and we are very happy to say that the Tamil Nadu government has made a new rule in which a student who has failed in the 12th exam can write the failed subjects within 1 month after the results so that he doesn't lose a year.
Low-cost suicide prevention programs like SNEHA's are now being initiated in other parts of India, China and Sri Lanka. The Schizophrenia Research Foundation, or SCARF, is also based in Chennai in South India. A WHO collaborating centre, SCARF provides care for a range of chronic mental disorders.
I think we eminently fit into this pattern of a low resource setting, working towards delivering mental health care to just about everybody who comes within our fold. We have developed a rehabilitation strategy which is fairly tailor-made for each person. The focus could be on training of social skills. How do you get into the bus? How do you buy a ticket? How do you go to the bank? How do you draw your money? Or it could be on getting a job.
My name is Suresh. I'm working as a manager in a public limited company in the Department of Quality Assurance. My case manager, she maintains my records. I tell her about my problems. She discusses with the doctor and they give me medicine. And I'm normal now. Thanks to my doctors.
MHGAP, establishing productive partnerships, reinforcing commitments with existing partners, attracting and energizing new partners. WHO's goal is to see that mental health is integrated into primary healthcare systems across the world. We have the knowledge. Our major challenge now is to translate this into action and to reach those most in need. We need to change policy, practice and political perspectives. Governments across the world need to see this as a health priority. The cost of providing basic care for these priority conditions is as low as $2 per person per year in low-income countries.
It's not about the money first, it's about the commitment, the love, the compassion, the will to make a difference. And I think it's the belief that you can make a difference.
1 in 4 people will be affected by mental, neurological and substance use disorder at some point in their life. These stories clearly show that with proper care, assistance and medication, millions can be treated.
My desire is that every Indian should be able to go somewhere close to his home and get mental health care.
They didn't ask to be here, they didn't ask to be like this, so they can't say, I need your help, so I'm giving my help to them in the best way that I can.
好了，也就是说基本上恢复的好了，这心理确实指数是啥，这个也是相当好的，这就是。
There is no health without mental health.
So in that context, I want to do 3 things. I want to talk about some of the challenges we face across the world in relation to mental health, about some particular way of thinking about how to develop services that may be applicable, particularly in low-income settings, then to offer you some resources that might be useful or interesting to you. First of all, what do I mean by some of these key challenges? So we've just seen that in terms of setting the scene from this film. First I want to refer to is called the treatment gap. Now, how many here have heard of this concept? Okay, maybe half. Okay, right. So what do I mean? I mean the proportion of people who do have a mental health problem, mental illness, whatever you want to call it, and who get no treatment. Let's just start with any treatment, no treatment at all. So we know first of all about the occurrence. If you look at the best epidemiological data we have, something like 20%, 18 to 25% each year of all of us in each country will have a diagnosable mental health problem. Across the world, we're doing a miserable job at responding to that challenge. The best we do is in the States. So we have data from Kessler et al. The National Comorbidity Survey showing that about 30% of Americans with a condition actually get treatment each year. The worst we do is in countries like Nigeria, where about 2% of people with all conditions actually get treatment at all, let alone effective treatment. And across Europe, it's about a quarter getting treatment, 3/4 not. So we know that we're doing a terrible job. Now, this disregard is really very striking. We heard 2 days ago major announcements both by Liberal Democrats for government and by Labour warming up to the election of mental health coming into play. And for the first time ever in my lifetime, beginning to see the prospect that mental health is seen by political parties in Britain as a vote winner, not as a neutral or as a vote losing issue. It's fascinating. So is this because we simply have not enough resources in low-income countries to provide care at all? So let's compare here 3 indicator physical disorders and 3 indicator mental disorders and look at the proportion treated. These are also data from the World Mental Health Surveys, this Ormel and colleagues. So if we start here, these are the poor countries, we can see that half or more of people with these conditions do receive some type of treatment. If we then make the inverse, which is in the richer countries here, we can see they only deal with about a third. So it's something like the opposite, 2/3, 1/3. So it's not the case that the low rates of treatment for people with mental illnesses in the poor countries are because of an absolute lack of resource. We can see it's because of a relative disparity, a poor distribution of resource between mental and physical health. Now let me say a little bit more then about the idea of coverage. Coverage is effectively the inverse of mental health gaps. So coverage is the percentage of people getting treatment of some sort. But we can actually do a little bit better and go into a slightly more variegated sense about types of coverage. Coverage that's available, let's say you could, in many countries which are low income, you might travel for a day or 2 days to get to a clinic. Coverage which might be accessible. In many cases people say, well, that hospital may be there, but I've heard terrible stories about what happens to people. That isn't acceptable to me or to my family. And then actual contact coverage. So I think I'd like to see the debate now moving from coverage into the idea of contact coverage, which is who's actually getting treatment, but even more onto the idea of effectiveness coverage, meaning treatment being delivered which is to some reasonable extent concordant with evidence-based practice. We actually think this treatment is likely to work. It's not having any treatment of any sort. This then raises a very interesting question about where we locate in this end of the spectrum traditional religious healers, alternative and complementary healer practices. So first is mental health gap. We actually aren't treating the large majority of people with mental illness in any country of the world, and the gap is huge in low-income countries. Second, I want to say a bit about early death. Often it's the case, and Martin and Dave McDade and other colleagues here will commonly meet policymakers in different countries of the world, and they will say, typically, HIV, malaria, TB, those are our priorities, now also infectious, immunisation, vaccinations, NCBs, non-communicable disease, to some extent we're getting interested in, that's where we're going to focus our investment. Mental health, well, we're very sorry, but it's not a killer disease, so we're not going to look at that just yet. You'll have to wait your turn, maybe in another generation or two you'll come around to that, but not just yet. You're not important enough. Well, that's wrong. So what's emerging now is interesting data about the extent to which people with mental illnesses actually die earlier than everybody else. Most of the data are from Western countries so far. Here's a study showing Denmark, Finland and Sweden. Light blue shows life expectancy after the age of 15. Dark blue shows life expectancy after the age of 15 for people who've been treated in the mental health system. And we can see that there's a 15-year decrement for women, 20-year for men, which has persisted over time while overall life expectancy has increased. These in 3 of the richest and most egalitarian countries of the world. So that was in British Journal of Psychiatry. And we've had very similar data actually coming out recently from Western Australia, and until now, very few data from any low or middle income country. There's a paper by Fekadu and colleagues in Addis Ababa about to come out in the British Journal of Psychiatry showing that in already a low life expectancy countries, about sort of 50 to 60 on average now, the loss of life expectancy there is 30 years among people with mental illness. So a huge proportionate loss of life expectancy. The third issue I want to touch upon is the question of human rights and stigma and discrimination. I have to be quite careful here, not because there isn't strong evidence, but in some countries people don't really like to talk about human rights, and you might have to go onto other economic grounds or coverage grounds or comorbidity discussions, and policymakers don't like. But in many countries there's actually a strong suit when you're arguing for stronger mental health care. So we know that in many countries, this is an example from our continent here in Europe, this is an example from the African continent, there are practices which do not comply, to put it politely, so essentially violate human rights agreements that have been solemnly signed up to by their respective governments. This is a Central European country where caged beds, some of them are ropes, some are metal bars, are used. And the argument is we don't have enough nurses, we're very sorry. If people have disturbed behaviour, they'll just have to be kept physically in a box or in a small space for the protection of others. And here there's also a resource argument used for practices that are often either poor or actually downright dangerous and disrespectful. Now, at the same time, we do have an instrument which applies to many countries. Most countries of the world have signed up in principle to this Convention on the Rights of Persons with Disabilities, a type of omnibus integrating arrangement for the United Nations, which actually sets out a whole series of rights, including the right to health as a separate section. In fact, it's not quite that, it's a right to access to health care, which that section describes. And many countries, but still only about a third in the world, have then gone back home, having signed this up in the United Nations, and actually incorporated it into national law. But these arrangements do exist now in many countries to be used. Rarely are they put into practice with respect to mental health law, but they're there ready as legal instruments to be applied in that way. It says, for example, all persons with all types of disabilities are holders of all human rights and fundamental freedoms. And there are a number of controversies associated with the CRPD in its own right. So a little bit about stigma. Again, I could speak for weeks on stigma, but I won't, just a couple of minutes. A couple of years ago, a few years ago, I had a sabbatical. I went off for a year, and I did one thing with that time. It was wonderful. And if all of you are multitasking, I recommend it to you to do one thing full time. It's great. And I said, I'm going to write a book about stigma, but in fact I didn't, because I wrote a book about discrimination instead. And I came to a simple view. I like simple things. And I like rules of three, so I used a rule of three. What is stigma? Well, it's three things: a knowledge problem, an attitude problem, and a behaviour problem. In particular, I wanted to focus the book upon this, about ways in which social exclusion applies to many, not all, but to many people with mental illness, as far as we can see in every country in the world where this has been studied. And so the book was very much focusing on the behavioural domain rather than the others. Now, if there are only two, if you're interested in stigma, and if you remember two words from today, and pedagogic studies suggest you might remember 0 words within 5 minutes, but if you remember two words, let them be these: social contact, social contact, social contact. What do I mean? I mean that the strongest evidence to reduce stigma in relation to adults is to have social contact between people with and without a specific condition, in this case a person with a mental illness. Now, is discrimination a trivial issue that I'm mentioning because that's what I do, but I'm overstating it? So here's a YouGov poll in this country saying who is discriminated against most. Now clearly my eye first went to the very important issue of people with ginger hair. I do have a little bit of ginger hair remaining, so I still may be discriminated against some of these grounds. And this does feature, but only a quarter, so I can dismiss that. I can be resilient against gingerness stigma. But right at the top here, above all the other groups you can see here, in a public opinion poll, people put mental illness as the strongest ground in this country right now for discrimination. Now again, there's a lot I could say, but I'll need to be very selective. There are now, for countries, for the national level, campaigns in up to about a dozen countries here, you can see, to reduce stigma and discrimination. And until the last couple of years, it's only Australia, New Zealand, Scotland, and then England that were doing this seriously. But now it's accelerating. All of these, as you can see, are high-income countries I'm not aware of any low or middle income country to date starting a national level stigma reducing campaign. And why? We can see some of the examples here about stigma. Science at a museum in Japan says those with mental disease are declined to enter the museum. The Lithuanian example is that people who are so-called severe mental illness can't hold legal contracts, can't own property, are denied a lot of normal civil and economic rights. This might interest any of you practitioners in the group. In Asia, 3 major airlines refuse to allow passengers with mental health conditions on a flight unless accompanied by a psychiatrist. So I'll obviously apply for a job in Hong Kong this will get my air miles. So let's give one example. When I wrote that book called Shunned, I wanted to shift the discussion from stigma into stigma and discrimination. It's a much more practical issue. We have discrimination and disability laws in many countries which are there to be used, ready and sitting and waiting. But we had very little research about discrimination, so we established a network, which is called Indigo, with colleagues in now in 39 countries around the world to find out more about this. The first study was for people with schizophrenia. We developed a scale called DISC, Discrimination and Stigma Scale. The items came out of focus groups, to begin with in 27 countries around the world, focus groups of people with schizophrenia, describing discriminatory experiences they had had, and then the scale built up from that. And what we then did, we talked directly to about 700 individuals in these countries, and we picked up a picture of their experience of discrimination. Most commonly by family members, by neighbours, by the workplace, and altogether about 90% described that they had had discrimination experiences. So that was in the Lancet. People then said, well, stigma's the worst, and they're chronic and they're very disabled and so on. It'd be much less if you looked at people with depression. We said, well, that's an empirical question. So the next stage we went on and did a second study which looked at people with major depressive disorder. The network had grown, it's now 41 sites in 39 countries. And we found very, very similar results. We found about 80% had discrimination experiences, the same profile. We then developed a new concept of anticipated discrimination. For example, why you wouldn't apply for a job because you expected your application to fail. We found that about 2/3 of people were limiting themselves in those respects around the world in many different contexts and cultures and countries. So it seemed, as far as we could see, that these are, in occurrence, universal phenomena, although the specifics are actually often culturally coloured by virtue of, for example, marital prospects being particularly very much damaged in South Asian countries and so on. So that's a little bit about some of the challenges that I want to highlight in terms of the global mental health scene. Undertreatment, the mental health gap, early death, and stigma and discrimination. So that's the end of my first part of my talk. This is a nice place where I can pause and invite your response. I know you're hungry, but anyway. Right. Good. Then I shall move on to part 2, in which I want to talk about one particular method of thinking about how you would go about planning for a local area to strengthen the mental health system. Now, the first thing to say is I need to pay tribute to my colleague Michele Tamsella, who's a colleague from Italy with whom I put together these ideas. And there's a short book, I like these little books, this is one of those little 100-page books we did, describing this model. To my amazement, it had a slow start, this book. It didn't sort of jump up to the top of the Amazon queue. But then over time, people have actually published this and translated it into different languages altogether, with a variety of beautiful covers I've been very pleased to see in these different language versions. So how would we think about, let's taking part of Georgia, or Chile, or Laos, or Fiji, and thinking about what sort of services should be developed? Well, we did a review of all the reviews which we thought were relevant in the literature. We found 143 review papers, and then we tried to synthesize the lessons from that evidence base. We came up with a number of overall conclusions. So if you're interested in a comprehensive system of care, whether it be in Birmingham or Burma, there's no good evidence that you can do that with hospital services alone, nor with community services alone, because of the range of people's intensities and needs. So it's a question of the mix or the balance. What investment to put into community, what into hospital or facility-based services. So we're talking about some balance, some mix, and the question is, what specifically would that mean in any particular time and place? We then set out a number of principles that seem to arise from this overview of the literature. First, that most people would like services either coming to their home or close to home. I'll expand upon that point a little bit later. Is that interventions should actually approach the whole range of difficulties people have, not just the clinical symptoms, but the range of disabilities or everyday living problems that they are likely to experience in relation to the mental health problem. That the treatment program should be specific to that person, not a sort of a chronic approach to a chronic person, but very specific to the person, also taking into account the priorities and preferences of that specific individual. And that part of this then leads to the conclusion that you would need a mixture of static and mobile services. And what do I mean by that? Static, sometimes called facility-based, where a doctor would sit, or a nurse goes to a building, sits in the building, and then sees whoever comes in front of him or her, goes home at the end of the day. But many people who have mental health difficulties won't or can't travel and get to a fixed facility site. In that system, they don't get care, they don't get treatment. Some of them are well, some of them are not well, and either maintain long-term low level of functioning and high level of symptoms, or have a chronic sort of relapsing and rhythmic, getting worse, getting better, worse and better. In Western countries where there are some services, they would be derogatorily called frequent flyers or revolving door, or people going through these sort of episodic gyrations. Whereas if you have a facility to go out and about to identify cases for treatment, but also to bring treatment to people who are not going to travel, you could actually help people to a better quality of life, more stable clinical picture, and a more active participation in the local communities. Now, the idea that a simple model could apply across the world is ridiculous because of the vast economic disparities in investment in health, let alone in mental health. So, for example, of the relatively small budget in Ethiopia for health, as far as we can tell, about 0.2% is invested in mental health. You can see here some indicators about health spending around the world. This is just proportionate, within countries. So what we've done in this model is to sync 3 particular scenarios linked directly to the World Bank, low, medium and high income country categories. Very interesting to look at that system year by year. Hungary has now slipped down to upper middle income country. Singapore and Hong Kong are now in rich and high income countries. There's actually a lot of mobility year by year with this classification of countries being located up or down. So let's look first at low. We'll say a bit about medium, and for today I won't talk much about high because I'm going to focus on low and middle income countries. So let's think of a country like Ethiopia, for example. If you're planning a service, what would you want to have in place? You would have to think almost entirely about what can be done in primary care. Why? Because of the scale of the need. We've seen up to 20, perhaps more percent of the population having a condition, and the disposition of resources on the ground, which for mental health, and for some of the regions of the country, is nothing, no specialists at all. So the only practitioners or services, which would include volunteers, but also lay health workers, community health workers, would be linked to primary care. So that's where the focus would be, to do almost everything in terms of case finding and any types of treatments that would be practicable. In that sense, what could specialist staff, psychiatric nurses, psychologists, psychiatrists, many countries don't have social workers, occupational therapists, what can they do? Well, mainly they would be active to support the provision of scaled up care to actually reduce the treatment gap among primary care staff. They would then consult, and this could include tele, and you saw Scarf in the film, they do a lot of teleconsultation with rural areas of Tamil Nadu. They do some limited direct treatment, but for the very most complicated and difficult cases, often in the capital city, people coming hundreds of miles for treatment. And that's really the limit. But often what they'll do is this, they'll treat a small number of difficult cases, and they won't think of themselves as having this multiplier role as the sort of master trainers for training of the trainers cascade, which I think would be more useful. So let's take one example. This is the main hospital in Uganda, in Kampala, called Butabika. And they have this sign up, which is their mission statement, a very sort of a modern thing. And it's quite nice phrasing, I think. What is their mission? To offer super specialised and general mental health services, so that's what they do to their inpatients and their outpatients. Conduct mental health training, including training of primary care staff in mental health skills. Research, and to provide support to mental health care services in the country. So that's really quite a nice summation of those different levels of direct and indirect training, teaching, practice and research. So then primary care is the main level, and then mental health specialists have a very limited role because there are so few. Ethiopia now has about 70 million people. It's got about, I think it's about 50 or 60 psychiatrists. 20 years ago it had 3. One was Bulgarian, one was Cuban, one was Ethiopian. You can imagine the interpretation challenges. So one model then is you take staff in primary care, usually staff who are state funded, who are sustainable, who will be there because their budget lines are there for the foreseeable future, and you skill them up. But that isn't the model that's necessarily the only one which would be useful. So let's take another one. This is in Enugu province, which is in the southeast part of Nigeria, it used to be called Biafra. And this is a man who is a community health worker, paid for by the local state, and so he's a sort of sustainable resource, at least his funding is. And his job is to go out to the villages and towns of the local area to find people with psychosis and to say to them and their family, do you know that in the local primary care centre there's treatment, and it's free, and it works, and you might well find it acceptable, why don't you come and try it? But he couldn't do that very effectively because he didn't have any money from the state to get out and about. So a German charity called CBM, Christoph Blindmission, gave him a bike. You can see he's stroking it lovingly, he's very proud of his issue there. So now that mixture of the NGO contribution plus the state ongoing salary allows him to go out and about to case find and to connect these people with his staff. And so many people are getting treatment, some psychological, psychosocial, often some psychotic medication, some of whom are now unchained, who have been chained and manacled for years, now who are playing a part in the sort of the farming activities of their family. So this then is about the idea of scaling up. So scaling up means taking an effective intervention that's been demonstrated in a smaller area, for example in a district or a country, and then writing it large, allowing large proportions of the population to benefit from an effective form of intervention or a package or a system shown to work in a particular country, for example. And there have been a series of papers now in The Lancet, the first series in 2007 on global mental health, the second series in 2011, describing many of these principles, but also these practices. This is one by Julian Eaton, who works at CBM charity I just mentioned. Now, a lot of this means that if you want to get involved, you have to have very close linkages, and McDave's an expert at this, and also Martin, between many different sectors simultaneously, without which it's probably not going to work. You need practitioner groups to be involved. Where they exist, you might well want services from family groups involved. You probably also want very close links with policymakers because they hold the strings to the resources that are available, which you would like to be disposed in effective ways. So here's an example. This is Dr. Sheila. She is the head of mental health policy for Uganda. And here she is visiting in one of the programs. David and I are involved in a number of programs in sub-Saharan Africa and Asia. And here we are visiting a site in the southern part of Uganda. And her colleague has actually literally got the T-shirt here. On the front it says World Health Organization, on the back it says scaling up, so she's proudly wearing the T-shirt. So what's the shape then? So let's think again about Ethiopia. It's quite a good example. So the most local level is called a health post. Small building, volunteers work here. Traditionally they were doing physical health and public health duties. For example, they would teach you how to build a pit latrine for sanitary arrangements. But they can be trained to detect somebody who's severely suicidal. So let's say they go to a village, they find somebody who's acutely suicidal now, they would then refer this person to the primary care centre. He would be paid general primary care nurses. Let's say they make a quick assessment, they think that person is an active high level of suicide risk today. So they could refer the person then to be taken by a special ambulance to the district hospital, where there would be a few psychiatric nurses, and perhaps there would be a psychiatrist with this as well. So that's how the chain would work, if it were to work well. Now, in many cases, I've talked about the contribution of the state sector, but in many countries, the state actually has so little resource, so little interest, that you really have to prime pump new ideas, sometimes longer-term projects, from the NGO, from the charitable sector. So one of these is called Basic Needs, which is a charity based in this country, which has projects in now, I think, about a dozen countries around the world, focused not so much on treatment, but upon occupation, work, vocation, activity, very much a sort of practical participation focus. So here's an example. This is in the southwest of Uganda. It's a place called Masaka. And this woman has had some severe episodes of depression. She's recovered a lot, and now she runs beehives, you can see here, selling honey. And she's known in her local town for her particular touch, because she has a very low mortality rate among her chicks. She breeds chickens, has eggs and breeds chickens, and she breeds very healthy, tasty chickens, so she's well known for her chicken farming credentials. Now, if you want to scale up, if you want to distribute sustainable, effective types of care in low-income countries, it'd be a great advantage to have lots of evidence about how to do that. But over 90% of the local studies actually come from high-income countries. So you're often the times thinking, do you plan on the few studies in any particular domain from low-income countries, or do you actually try to import high-income country data and then adapt it? Better to do the former where you can. So here's an example then. So this is a study that's just been completed of a trial of community care in India. You can see here the aims. It's a randomized controlled trial funded by the Wellcome Trust, I should mention. And it's to evaluate basically a community mental health team approach for people with schizophrenia compared with treatment as usual, which is called facility-based. So this is the distinction I mentioned earlier. Mobile, these are community health workers, relatively low-cost staff, going out and about, versus fixed site or static doctors sitting in rooms. And we had the great, I'm not sure it was wisdom or luck, but we carried out a so-called formative stage. For the first year, we didn't dive in and do the trial. We spent a whole year talking to people, saying, you know, we're thinking about this, what if, would you like it, would it make sense, testing out acceptability. And so we went to people in villages saying, if it was possible for someone to come to your home and to meet your daughter or your son who has this mental health difficulty and come and see them here at home, would you like that? And many of the families said, well, it's very nice of you to come and sit down and have a nice cup of tea and so on. And you're very welcome today, but we wouldn't like you to come a second time. And we said, what? We were offering community care and helping your family. And they said, because if you came another time, the villagers would start saying, who were they then? What are they coming for? They would have to say, well, they were mental health people. And they said, well, surely everybody in the village knows that your son, for example, has mental difficulties. They say, yes, but they don't officially know. So there's still a level of official deniability. If you come back every time, then we couldn't maintain that level of sort of anonymisation. But if you do a clinic in the next town, we can get there in half an hour, that'd be very handy. We still maintain that degree of privacy. So that's what we did. So we have to adapt the model according to the cultural requirements of the people concerned. So with 3 sites here in Maharashtra, in Goa and in Tamil Nadu, the lead in Tamil Nadu, you saw earlier Dr. Tara in the film, lead from Goa is my colleague Vikram Patel. And basically we ran a randomized trial. Not so easy actually in any setting, including in a low-income setting. So I want to give you a hint about what this setting was like.
एकदमच मला कम से कम 5 मिनिटं आवाज माझ्या कानाला मी देव बोलतोय असं तसं.
मानसिक आजार हे काय असतं हे मला याच्याबद्दल काहीच माहिती नव्हतं. म्हणजे हा प्रकारच माहित नाही. मला काहीतरी म्हणजे समाजात वर्तनात काहीतरी आहे असं मला सारखं वाटायचं. पण कोणापुढे बोलायचं हा एक माझ्या मनामध्ये कुचंबणा व्हायचं.
आजूबाजूची लोक ते दृष्टिकोनातून बघायचे तिच्या येडीचे हसती बघा कशी. कोण माणूस पुन्हा येणारा असला तरी त्याला असं वाटायचं ती माझ्याकडेच बघत हसली म्हणून तो माणूस असा बघत उभा राहायचा. मग मी ती उभी राहायचे. मी 2-3 माणसांना बडावलं लगे त्याच्यात.
वाईट वाटायला लागलं की झाडाला धरायचं रडायचं. कुणाला सांगायचं नाही असंही म्हणून.
तसं देव वगैरे गेले लाग बांधून नाही गेला बरं का. जेव्हा ह्या देवाला जात त्या देवाला जात त्या अमक्याला पाळा प्लेट पाळा लांब ले जो 5-6 महिने आम्ही राखवणं देवाचा आहे. हा प्रमाण उलट देवा वगैरे जास्तीच वाढायचं तर कमी नाही.
कॉप्सी हा प्रकल्प जो आहे तो त्याचा लॉंग फॉर्म असा आहे की केअर ऑफ पीपल सिझोफ्रेनिया इन इंडिया. म्हणजे औषध उपचाराव्यतिरिक्त जर काही सामाजिक उपचार पद्धती जर या लोकांना चालू केली,
डॉक्टर आणि पेशंटच्या मधला दुवा असा आमचा रोल होता.
म्हणलं पाठवा घ्यायची सर, बरोबर, कारण आम्हाला माहिती आहे कसं कसं काय बोलायचं, कसं काय करायचं किंवा काय करायचे, कसं त्यांच्याशी वागायचं, कसं काय म्हणलं आम्हाला माहिती मिळेल.
हे तुम्ही जे प्रोग्राम हे ठेवलं होतं ना, हा, तर त्याचा पुरेपूर फायदा आम्हाला झालाय. म्हणजे औषधांचं तर झालंयच, पण औषधांपेक्षा पण ते जास्त म्हणजे संभाषणाने यांच्याशी व्हायचं ना, बोलायच्या.
जोपर्यंत जमेल ना तोपर्यंत तरी काम असावं आपल्याला असं वाटतं. जोपर्यंत जमेल तोपर्यंत. दिवसभर म्हणजे काही विचार वगैरे काही येत नाही. दिवसभर याच्यात मन रमतं ना.
आता जरा बरं आधीपेक्षा बरं. कामात पण जाते त्यामुळं शाळेचा खर्च आधी नव्हता, पण आता खर्च आलाय ते मम्मी झाला.
Work is not just for money. It is for self-esteem. It's what you think about yourself. It's the way you spend your time. It's your productivity. It's what you give to society, what you get from society. So when they start working, then they feel much better. People learn to respect them. They start liking themselves.
आत्ताची परिस्थिती आणि त्या टायमाच्या परिस्थितीमध्ये किती आसमानचा फरक. म्हणजे माझा अंतराळ नसतंय इथून पुढे जे तुम्ही चितलेलं काम आहे, जे माइंडमध्ये तुम्ही ठरवलेलं पुढं लई त्याचं चालना मिळालं.
So I hope you get a bit of a sense about the setting from that. So we then carried out these interventions with families usually, a mixture of psychosocial and sometimes usually pharmaceutical intervention as well. And you can see it's a sort of skill sharing idea with the active ingredients being these community health workers, relatively brief training who are suitable to go out into towns and villages. So what do we find? Well, just to summarise 3 years' work in one slide. Symptoms did improve, disability did improve, and most of that, at least the symptoms, seemed to be because we were able to increase treatment adherence alongside the family and the individual psychosocial support. So then just a brief word about middle income settings, much of Southeast Asia, much of South America, for example. The emphasis still, for those simple epidemiological grounds, on strengthening primary care. And then, as resources allow, we can start to fill in details in these 5 main categories. Ambulatory stroke outpatient care, mobile teams, limited inpatient teams, mostly longer term accommodation in community settings. Martin is the sort of international expert on these things. But also, as you've seen, work and occupation. This last category often neglected or omitted. And then just a word then about high resource settings, still these 2 building blocks, and then more differentiated, more specialised forms of this acute general care. I'm talking here about adults really, because of my own limited experience of other groups. So if this interests you, there's a book, there's also papers, and I'd be happy to send you all these published paper materials if you like. A longer paper in psychological medicine from a couple of years ago, and also a leader here from the British Journal of Psychiatry. So a bit then about a few resources. If you want to get more materials, you're very welcome. And there's lots of stuff about guidelines for treating people in different countries and setting up services. This is a World Psychiatric Association set of guidelines that we produced. Continent or region-specific guidelines as well. Open access papers from World Psychiatry. This is an example of one from Southeast Asia. There's books, if you're interested in this, on global mental health. One of this is more detailed accounts of experiences of setting up community care in different countries. And I think I particularly want to mention this. Now, how many of you have heard of the MHGAP Intervention Guide? A few, okay. So then just a word about this. In my view, this is one of the most important things that have happened in global mental health in decades. Until this, the World Health Organization largely limited itself to so-called technical assistance, namely saying to governments what governments should do. He's had to make a policy, he's had to make out a plan, he's had to make a strategy, he's had to make a law, he's had to think about human rights. This is nothing much to do with governments, because these are guidelines for primary care, general staff, on the treatment of individuals. And it's a series of, you can see it's for low-income countries, a series of algorithms or guidelines like this, designed to be clear enough, doable enough in primary care settings in low-income countries. If you're interested in emergency or disaster or humanitarian settings, we produced a guideline, a method to assess the needs of people, and this is freely available as well. If you're interested in monitoring human rights in institutions, we have a method of doing this. And again, I can make all of these available to you if you have a particular need. If you want this chapter and verse, there's a great big thick wodge of about 50 chapters setting out the evidence for many of these specific forms, in fact, both hospital and community care. If you're interested in one particular method, namely randomized controlled trials, I've just published a book with my colleague, Vikram Patel, on how to do that. And if you want to know much more detail, then I'd like to advertise our MSc course, a mere stone's throw away in London School of Hygiene and King's College, where we offer a wonderful one-year programme. If you're interested in developing services, we offer a consultancy offer as well, called Morse International. Now, I'm going to switch, for just a couple of minutes if I can, switch mode. So far I've been in sort of academic didactic mode. I'm now switching into activist advocate mode. Millennium Development Goals. How much does it say about mental health? Madam, you're shaking your head. Nothing. Absolutely right. Absolute zilch. Nothing in the Millennium Development Goals about mental health whatsoever. To its shame of that process. You may well know that now discussions are well advanced on their successors' Sustainable Development Goals for the next 15 years. 17 goals have been identified, 169 targets have been identified. Just seen a statement today about the lead person at United Nations running this, saying it's unlikely they will reduce those number of goals or targets, interesting enough. And what does it say about mental health? At the end of target 3.4, it says, non-communicable diseases, mortality will be decreased by 1/2, comma, and something like, and mental health and well-being. There's 5 words, that's it. So we're not excluded, but we're effectively completely marginalised at the moment. So I've been tracking this, and in the summer I got fed up. So I said to my colleague, let's start to make a fuss about this. Let's do something and try and get some momentum to strengthen the mental health component of the SDGs. So we did a leader, BMJ said they'd take it, and they did. And then we've done further work. There's a number of papers now. This one came out a couple of weeks ago in Lancet Psychiatry, led by my colleague in Nigeria, Oye Gureji, basically presenting different facets of the case. Why mental health isn't just per se an important area, 23% of global burden of illness, global burden of disease. It's not just a case for comorbidity, because rates of depression will be twice as high in people with HIV and malaria TB than in the general population, and will interfere with HIV treatment if not addressed. But also the wider cross-cutting elements, the impact on education, in the workplace, you name it. Mental health's everywhere. It's a cross-cutting issue. And we've just done this one about how to learn from what's happened in HIV and TB and so on as well. Another paper just publishing at the moment. So we call then, you may say it's a bit presumptuous, but somebody has to do it, we're calling upon the United Nations to strengthen mental health. And in particular, we're making very specific proposals, not just saying do something, we're saying do this. So in the plain type, you can see the current health goal in its entirety. And the yellow bits are the suggested edits that we want the United Nations to take on board. And we then, we is 40 different organisations now around the world which have joined together in this initiative. And then a man came to me who is a New Zealand photographer who'd done a photo montage journey for a year around Africa. He said, can I help? I said, yes, you can. So he said, well, I'd like to do a film. He said, that's great. So we are now doing our very best to create momentum to make these changes. These are some quotes, deliberate and concerted campaign and so on. Very important. These are quotes from people around the world who've been posting up their notes of support. You're very welcome to get involved to support this. The key mechanism now is to contact ministers of foreign affairs, whatever they're called in different countries, and ask them to write to us, but also to write to their special envoys in the United Nations to bring this into account over the coming months when we have these debates in the United Nations. The next 2 or 3 months are critical. Full details are available here, including template letters, the film, all sorts of other materials and so on, and you can also follow us on Twitter. So to summarise, I want to do 3 things, and first was to say some of the key issues and challenges in global mental health, namely treatment gap, early death, stigma. Then come to say a bit about a particular model which indicates a need both for some static and some dynamic or mobile services, very much according to the resources on the ground, but also the cultural conditions in each country. The third said about some resources, including this fundamental SDG initiative that's been established recently. If you want materials about community mental health, implementation, or stigma about global mental health, please contact me. I can invite you to Dropbox folder, and there's lots and lots of materials, there's scales, there's PowerPoints, there's films, there's papers and so on as well. So on that note, I'm aware that the implementation of the sandwich system seems to have fallen down. Oh dear, there's something outside. Okay, so back to Martin, thank you.
Okay.
I shouldn't say that because I'm moving a question.
No, you don't know your lunch just yet. So thank you very much, Graham. Let's quickly go for questions and comments. So please, feel free. Graham, let Graham can manage that.
Oh.
Okay, so I think you go first.
Very, very interesting, more particularly a randomised controlled trial of care. But there's one item that you haven't fitted in, namely prevention. And how do you fit in, for example, vaccination, which is an extremely effective method of reducing the burden of mental illness in the population?
And in what way does vaccination reduce the burden of mental illness in the population?
If you read for example, there's a book by Ernest Greenberg from the National Institute of Mental Health, who showed that vaccination programs reduce the incidence of epilepsy, mental handicap, and so on. Vaccination against measles, mumps, and so on, complications of which are epilepsy, brain damage.
So I think that's right.
And it's he showed how cost effective.
So the focus here is on what's now called the Global Action Programme of the World Health Organization, which was about a year ago signed up to by the 194 countries of the General Assembly of the WHO. the emphasis for this particular programme is very much on the treatment of people with current conditions, and there are separate areas of policy for prevention and so on. So don't stay on the treatment side or on the prevention, but you're right. Thank you.
I mean, I think it's important, very important, to consider that much of the things that you showed in your first film can be prevented through appropriate vaccination programs.
Well, I'm not sure actually. I'm not very knowledgeable about prevention issues, but the depression, for example, I'm not aware of any immunisation for schizophrenia or bipolar or many of the so-called functional problems. But for some of the neurodevelopmental disorders, I think you have a good point. Thank you. Somebody here, thank you.
Hi, thank you for your presentation. You talked about a way to reduce stigma is for social contact, and I was just wondering how do you go about doing that on a wider scale?
Okay. So let's take an example from this country. How many people have heard of time to change? Okay. So across England, it's now about 45%. So you're a representative sample of people in England, wherever you're from. And this is a campaign running now for 6 years, designed to reduce stigma and discrimination in the population and in specific target groups. And so it's a multi-level approach. Social contact is the critical element, either person-to-person or virtual contact through filmed or other media. And the key for social contact is disclosure. It means somebody saying, I have either a mental illness or experience of a mental health problem, because time and again we see that social contact is the prime to reduce stigma and discrimination in people without that experience. The paradox is that we all, or virtually everybody, knows somebody with mental illness because it's so common. But many of us don't know that we know somebody because they're busy keeping it quiet, they're concealing because it's so strongly stigmatised against. So the idea, the turnkey idea, is to allow more and more people to feel comfortable disclosing, so more people around them have knowing social contact, and therefore at a population level will reduce stigma. So we've shown, for example, across England, a reduction of about 3 or 4% in stigmatising attitudes over the last 6 years. We used the framework I mentioned of knowledge and attitudes and behaviour, and at the beginning we hypothesised that the least effect we found in the behavioural domain in discrimination, because any awareness might filter through and be diluted, and we were wrong. We found in the first 4 years of this national campaign an 11% reduction in stigma as described by people with mental illness across it's 1,000 people we phoned every year who are a representative sample. So it's based upon social contact principles, and then you can look at different whole population samples or subsamples to test if you're having an effect. I'm going to be happy to send you lots of material about this.
Yeah.
Okay, thank you. Next question, please. Dave, and then let's see.
Yeah. Building on your life expectancy issue, I mean, Stark, it's well known, is a disgrace, actually, quite frankly. But in terms of what you do about it, I just wondered, could you put more emphasis on the benefits of better mental health or early intervention from a mental health point of view in terms of prevention or better management of the physical health problems that may be of more interest, rightly or wrongly, to policymakers and government in countries?
So let's then pick up the example of the Millennium Development Goals. There's a strong consensus in the development and in global health field that this has been tremendously powerful to shape two things. First is donor behaviour, second is national government behaviour. The donors, especially Global Fund, PEPFAR and Gates, have pumped billions of dollars into these three conditions. And that's transformed the expectancy of getting treatment for HIV in many countries. Second, it's brought the attention of national governments to these conditions, because every year there are league tables, for example, of coverage. You can say Botswana, 2013, 67% of people with HIV getting treatment, and you want to improve that and go up. Absolutely, but also countries start to look around at their comparators, saying, oh, well, Malawi just got 73%, and why haven't we yet? So it really shapes governmental behaviour, investment, and mobilisation, so it's very powerful. So far, those big donors have shown virtually no interest in mental illness per se. There is a meeting and planning of the World Bank on depression coming through, so maybe it's beginning to see it turning the tide. But so far, the argument that they might want to invest in mental health itself has fallen on absolutely deaf ears. But there's another way. So, for example, I'm having a trial at the moment in South Africa with colleagues for people who are HIV positive and are depressed. Why? Because if you're getting antiretroviral treatment and you've got HIV or AIDS, you're more likely to have a 30% than a 15% chance of depression. If you've got both, you're more likely not to comply with the antiretroviral treatment, and then you're more likely to die. So even if you're an AIDS charity or funder and you want your best outcomes for survival and better quality of life and functioning for AIDS, we can help you if you concurrently pay attention to mental illness issues by virtue of treatment of depression. So the comorbidity argument in principle is a very powerful one. We haven't activated it at international policy level very much yet. And indeed, the evidence base isn't yet very strong, but it's just waiting there for us to exploit, first for the evidence and then for implementation. Does that begin to answer your question?
Yeah, absolutely.
Okay.
It just seems to me it's a way to reach those who are not interested.
Okay, thank you very much. Yes, please.
My question would be around the Sustainable Development Goals. What will be the role of global mental health up to you in the new Sustainable Development Goals? What would you suggest to be the role?
Do you mean what to do or how to activate it if we were included?
How to include it within the Sustainable Development Goals,
okay.
And what to do with it.
So, I'm being filmed, so I shall choose my words slightly. I've been actively encouraging the Department for International Development to play a leading role to move to strengthen mental health in SDGs. Indeed, recently I met a number of ministers there who are showing interest in this, I must say. They also said which other countries, especially which low-income countries, are on board with this, because at the moment, because of the advantages and the progress made for HIV, malaria and TB, every other health and disability sector is jumping on SDGs, saying we want to be a part of this. They think that their cake's going to be massively swollen by being actively explicit, including SDGs. So that it's an advocacy, punch, fight, and frenzy. So for any government, they're being lobbied simultaneously by glaucoma and trichomoniasis and people with hearing disabilities. Everybody's wanting to be involved. And one of the things they say, well, how many other countries are prioritising this? So countries are tending to hesitate a bit, thinking, well, is there a consensus? Is there a caucus? How strong is the feeling? And they're in that sort of slightly hesitant state right now, thinking, would we be part of a strong majority or consensus if we actually made a big issue about mental health? So that's what we're trying to do. So across these 40 organisations, writing to many governments saying, we'd like you to make a clear statement that mental health is a priority, and you want your government and your representatives in the United Nations to argue for that when it comes to the critical discussions in the coming months. What can we do as individuals is to write to our member states, it's particularly the overseas or the foreign affairs minister who's the critical person. And I didn't realise this until recently. Not only do they have ministries of government, they have a type of embassy to the United Nations. The person there isn't called the ambassador, he's called the mission. And he then has his officers. The critical person would be called the health attaché, who would be mediating those negotiations. So you've got to try and understand the way in which the United Nations works. So it's getting through to the Foreign Affairs Minister, asking them to instruct their mission, and then to ask them to instruct their health attaché to make a strong mental health component in the SDGs. And it's pushing to all of our countries simultaneously. And I very much hope that this country will play a leadership role in convening that new consensus. Does that answer your question?
Half.
Half. Oh dear.
Yeah, sorry. The other half would be, do you think of mental health like if it was to be within the Sustainable Development Goal? Do you think about mental health in itself or like pushing the other Sustainable Development Goals?
This is interesting because, of course, mental health is such a cross-cutting issue. You can argue its importance with respect to employment, to education, to parenting, virtually anything. The way in which the goals work is that the wording, if we go back, for example, to the wording I showed you here, the wording here is a sort of resultant of years of sustained lobbying. So here we've got halve the number of global deaths from road traffic accidents. Those words don't come out of nowhere. They come from very concerted and sometimes actually well-funded lobbying over years to get that sort of wording into a statement like this. So if you then say, well, that's linked to alcohol, let's put, and alcohol-related substance use disorders, you might say, well, that'd be cross-cutting, that makes sense. No, it doesn't, because the road lobby doesn't want any change, that exact wording. They've spent years, crafting this particular narrative. But what you can do here, for example, universal health coverage is a critical issue. And it looks like this may well survive. Now, that in itself is a fine principle. But let's look at the detail of the wording. achieve universal health coverage, this is the addition, including financial risk protection, access to quality essential healthcare services and access to safe, effective, quality and affordable essential medicines and vaccines for all. So that seems to be very sensible. I mean, you've got a sensible person to argue against that. But you can imagine any particular government might say, okay, now, what is an essential list of healthcare services? What's the essential minimum amount? And governments might well say, well, unfortunately, we're not going to put mental illness into that minimum essential category. Which is why we want to make it quite explicit here, physical and mental, so that universal health coverage applies to the full range of all those conditions. Otherwise, you can see it slipping off with that weaselly word here, essential, for example. So it means trying to create a sort of word safety net, so it can't be disregarded by nation states as it has been until now.
Thank you. Okay, I think we better draw things to a close. I want to just thank Graham enormously for a very interesting presentation. I hope that you'll have more Twitter followers and the SDG goals will get more supporters. So please go away and tell everybody else in the street about that. So thank you very much, Graham, for that. Let's thank Graham.